So today, welcome to October 4th Head and Neck Live. Today is our third of our resident lecture series, and we have Dr. Maggie Parkhurst who will be presenting to us this morning. So thank you guys for joining us. So Dr. Parkhurst, she's one of our PGY3 residents in our Otolaryngology-Head and Neck Surgery program. She was born and raised in Bethesda, Maryland, and attended University of Richmond for undergraduate studies, where she majored in biology and minored in Spanish. And she did a little research in Lyme disease. So if you have any questions about Lyme disease, she's the one to go. She then attended George Washington University for medical school, where she decided her dream was to become an otolaryngologist. So here she is. So she's here with her husband, Chip, and her dog, Lola. And she enjoys spending time with her friends and family in her free time and likes bringing people together as the unofficial or official social chair of the residency. So this morning, Dr. Parkhurst will be presenting on her research on facial paralysis, review of Bell's palsy, quality of life impact, and socioeconomic differences in treatment. So thank you, Dr. Parkhurst.
Thank you, Dr. Koo. Can everyone hear me okay? All right. Okay. So here's just a brief overview of the presentation today. So we'll start with a little refresh review of Bell's palsy, some treatment options and treatment standardization that we're trying to implement here at the clinic with a new EPIC order set and best practice advisory. And then we'll just review some of the quality of life impacts and why some of this matters so much, aside from a functional standpoint, but from a quality of life standpoint in the literature. And then look at treatment differences related to socioeconomic factors, some review of recent literature, and then review of the area deprivation index metric, which is what we used in our study here at the Cleveland Clinic, looking at our own patients. So starting with the review, about 70% of acute unilateral facial paralysis is diagnosed as Bell's palsy. And then some other conditions that can cause facial paralysis, as we know, include stroke, brain tumors, tumors of the parotid, cancer involving the facial nerve, systemic and infectious diseases like Lyme disease, zoster, and sarcoid. So this is Sir Charles Bell. He described Bell's palsy in 1831. So it can be a partial or complete paralysis. Partial paralysis definitely has a better outcomes and better spontaneous recovery, with over 90% of patients spontaneously recovering in the first few months. We'll get into the complete numbers below. The incidence ranges from 13 to 30 and 100,000, and it most commonly presents between the ages of 15 and 45. May be accompanied by some other symptoms, which can include altered sensation and the distribution of the sensory glossopharyngeal and trigeminal nerves, so the face, ear, pharynx, and posterior tongue. And up to 80% of patients report this. And then also about 60% of patients report facial retrocervical pain, and then altered taste in about 57%, intolerance to loud noise in about 30%, and then there's some others that are a little less common. So for those that do regain function, there's a bimodal distribution for regaining function, most commonly either at 3 weeks or 3.5 months. Older age has also been shown to be linked to less spontaneous recovery or less likelihood of spontaneous recovery. And so for those who have complete paralysis, about 70% have full facial function return within 6 months, but that leaves 30% that do not fully recover. And if they don't fully recover, that means they may still suffer from residual paralysis, asymmetry or synkinesis, which is the unwanted contractions of the muscles of the face during attempted movement. So most commonly, it's forceful eye closure with attempts to smile. And this is sort of what we want to address with our order set. So here you see the Academy guidelines for treatment. And so they recommend against labs and imaging, and they recommend oral steroids within 72 hours of symptom onset. The dose should be a 10-day course with at least 5 days at a high dose. So some examples here: prednisolone 50 milligrams for 10 days, or prednisone 60 milligrams for 5 days with a 5-day taper. Combo antiviral therapy is optional. It should not be monotherapy, but it's optional to add on. And then eye care is really important so that they don't have any damage to their eyes. So a moisture chamber, eye drops. And then this last bullet point here, referral to facial nerve specialists for any patient with new or worsening neurologic findings, ocular symptoms, or incomplete recovery 3 months after initial symptom onset. But as we all know, a lot of these patients, after they're discharged from the ED or primary care, if they don't have complete recovery in 3 months, it might be hard to get into a specialist within 3 months before that 6 month window, which we'll get into. And so that's what we're trying to improve here. So this is a study from our very own facial plastics team here, looking at our institution and patients with Bell's palsy and their treatment outcomes. So this study looked at 903 patients. Most of them presented to the ED, 76%, but others presented to internal medicine, family medicine, or urgent care. 89% were given steroids, 65% were given antiviral therapy, a good amount were given eye care, 64%. A good amount had imaging, but most of those imaging were CT head without contrast, rule out stroke. And then here's where we sort of see a little bit of an issue. So the steroid treatment ranged for 1 dose to 14-day course. Only 20% though, when we looked at the duration and adequate dose of steroids, only almost 20% had adequate duration and dose of steroids. So definitely falling short there. Referrals to facial plastics or ENT was only in 5.6%. We did find out that a larger majority were being referred to neurology. And 31% of patients had complete resolution, 21% incomplete. But the big issue here is that a whopping 40% were lost to follow-up. And so that goes back to the last slide and the last bullet point that these patients aren't following up. So there's definitely some of them out there who have residual facial paralysis and are not getting the treatment that they might deserve. And then just a little tidbit of those that did follow up, which was not very many with us since only 5.6% were referred. 18 underwent surgical intervention, including ectropion repair, eyelid weight implant, blepharoplasty, 5 to 7 transfer, cross-face transfer, brow lift, and 5 of them received Botox injections. Here's just a brief review of some of the interventions that when patients do follow up, they might receive. So physical therapy, generally when patients are starting to recover more early on spontaneously in their course, then we'll try physical therapy to get their face moving well again. And then Botox or chemical denervation and selective neurectomy or myectomy for the patients with synkinesis. And then the facial reinnervation procedures, though, are reserved for the patients that aren't recovering spontaneously. And so if there's no function at 6 months, at that point is when you're going to want to start to consider doing some of these. And these are very time sensitive as they depend on viable nerve or motor end plate connections. So should definitely be performed within 6 to 12 months of paralysis. And that just stresses that these patients need to have follow-up sooner and need to be connected with someone. So I don't have a slide for our order set endeavors, but we're working with the emergency room now to create a new order set for Bell's palsy, and we'll be tracking this. I think since it was implemented in April of 2020, their old order set, it had only been used 21 times. So it hasn't really been used that much, and that might explain why so few patients are getting the right duration of steroids and dose. So switching gears now a little bit to talk about the quality of life impacts. So about 65% of patients with facial movement disorder have depressive symptoms. Obviously, that's pretty significant and something that we want to address. So a study here published in Laryngoscope in 2011. So this study, the objective was to characterize the perception of attractiveness for paralyzed faces, and the study out of Hopkins. The authors of this study hypothesized that paralyzed faces would be considered on average less attractive than normal faces, and this difference would be amplified possibly by smiling because of the paradigm of symmetry. And so this study had 40 participants who took survey. That's sort of the participants were survey participants. And they were comparing patient photos from archives, and those were demographically matched to non-paralyzed patients. And so here's an example of a picture that they might be shown. All patients ranged from a House-Brackman score of 4 to 6. And so the survey questions were designed to measure how observers perceive these faces. So they were asked if the paralyzed faces were normal, like yes or no questions, whether they had facial paralysis, and if so, on which side. And then they were asked to check the affected areas, so like eyes, lips, and see which they got right. Then they rated the severity of the paralysis on a scale of 1 to 10, where 10 was the most, and the attractiveness of the face on a scale of 1 to 10. And so here are the results from the attractiveness part. So here we see that the mean attractiveness score was significantly lower for the paralyzed patients, so 3.3, and that increased with the increasing level of attractiveness. But the effects were actually not affected by smiling. There was no significant difference with smiling, making it any worse. And then here's one more study on the quality of life impact. So this is another study, investigated facial expression of emotion and quality of life in patients after long-term facial paralysis, so greater than 1 year. And so this was a study for 24 patients, and then each were paired with a significant other or family member. There were 6 emotions that they looked at. So that was happiness, disgust, surprise, anger, sadness, and fear. And so there were 12 patients who considered themselves effective at portraying all of these emotions, and then 12 who considered themselves not effective at any one or more of these. And then they were assessed by different physical functioning grading scales like the House-Brackman, and also by quality of life questionnaire, the SF-36, which is a standardized quality of life questionnaire. And here's a graph just depicting, I thought was one of the most significant parts. So here on the y-axis is the SF-36 scale, which is graded on a scale of 0 to 100, with 100 being the highest level of functioning. And so these categories in the physical section are physical functioning scores from the SF-36. And so the patients who deemed themselves effective felt effective both at physical functioning and social functioning, but those that felt not effective at expressing those emotions felt somewhat similar at expressing themselves, or somewhat similar physically, but really drastically had a negative impact on social functioning. So social functioning was much more impacted. Okay. And so now switching gears a little more, now moving on to the socioeconomic factors of facial paralysis. So these are 2 studies in the recent literature. So the first one is from 2022, and this one was a NISQIP study that compared sex and race disparities in surgical management of facial paralysis patients. So some of the interesting things that they found was that 90% of the patients who met criteria that meant therefore underwent a procedure at all were white, and that white patients were more than twice as likely to undergo brow ptosis repair than non-white patients. And then the second study from just this year in March, this compared 2 databases over 6 states, and they found that so they actually had quite a lot of patients in this study. So over 20,000 patients with facial paralysis, only 515 underwent surgery, and they found that Black patients were significantly less likely to undergo surgery, as were with patients with Medicaid or self-pay insurance. And then they also found that those living in rural area were significantly less likely to have surgery. And then those in the inpatient setting were most likely to have private insurance, whereas those in the ambulatory setting were more likely to have Medicaid. And so now that brings me to talk about this relatively newer metric, which we used in our study. So this was developed by the University of Wisconsin, a researcher named Amy Kind in 2018. So it's called the Area Deprivation Index, or ADI for short. And it's based on a measure created by the Health Resources and Services Administration. That was created over 3 decades ago, but it's since been modified and refined, adapted, and validated to the census block group data. So that's the data that the Bureau of Census uses every decade. And so it allows for rankings of neighborhoods by socioeconomic disadvantage and a region of interest. So either at the state or national level, and I'll show you Ohio's example in a minute. It includes for factors for theoretical domains of income, education, employment, and housing quality. So there's 17 sort of indicators within those that they take into account. And it uses data over the course of 5 years. And so the interesting thing about this is that they block by neighborhoods. So it's separated by streets, roads, railroads, bodies of water, physical barriers. And so if you look at Ohio, you can see like in Cleveland, for example, a more metropolitan area of Ohio, the block groups are tiny because there's a lot more physical barriers separating things and separating areas that might be more disadvantaged than others, whereas rurally, the block groups are much larger. And just a real life example where this was used in this past May, this was used by Milwaukee Waterworks for their water quality equity plan for the city of Milwaukee. So it has some real life implications. And so if you just look at Ohio, basically how this works is it goes from 1 through 10. So 1 is the lowest level of disadvantage. And so for the state level, it goes through 10. So it's deciles. So here's Ohio on the state level, as you can see on the bottom, 1 through 10. But then when you compare it nationally, this is Ohio on a national level. So it gets much more disadvantaged when compared to the whole United States. Yeah, so it's interesting. That's the website up at the top. It's kind of fun to like type different things into it. All right, so in terms of our study, so we basically looked at facial paralysis patients over the last 10 years at our institution who presented to our department using ICD-9 and 10 codes, and that ranged from the years of, I believe, May 2013 through May of this past year. And we compared no treatment, surgery, Botox, or both amongst all these patients at our institution. We had 437 patients, 272 were females, and 165 were males. Here's just some more of the demographic information below. The House-Brackman score on average was 3.8, but we only had the House-Brackman score recorded for 165 of those patients, so it wasn't quite as robust as 430. Surgery was the most common intervention, and private insurance was the most common, with Medicare being the second most common. And then for most of our analyses, we looked at the national ADI because a lot of our patients, although they're from Ohio, we still had a large number that were from out of state. And so taking all of those out of state people out would definitely decrease our numbers a bit. So we just compared them nationally. But there's probably future things we can do with comparing just the state. So from some of these demographic information, we found that females have 3 times the odds of undergoing a non-surgical intervention compared to males. And the odds of a patient with Medicare undergoing surgery are 5 times greater than the odds of a patient with Medicaid undergoing surgery. And then this it compares ADI scores of both state and national to different treatment types broken down by male and female sex. We did not find a statistically significant difference here, but the main sort of gap was in the no treatment group. It was close to significant. So females and males, essentially the females were less disadvantaged when they had no treatment compared to the males. Here's the national ADI here, and this was probably one of the more interesting things that we found. So we used multivariate regression to compare the ADIs, and we found that for each 5-point increase in the national ADI, the odds of undergoing surgery increased by 12%. So that's interesting because that actually means that the more disadvantaged you are, the more likely that they were to undergo surgery by 12%. And we tried that on a few different scales, but 5 points seemed to be the most interesting. And that's just a breakdown. Our patients, as you can see, were pretty much evenly distributed, like pretty normal distribution of patients on a national level. Here's the House-Brackman score, and that's a histogram of just the total amount of patients over there. So for each unit increase in House-Brackman score, the odds of undergoing surgery increased by 97%. So that was significant, but that makes sense as well. And then here we tried to break it down by types of surgical intervention. So I'll just go through a few things that were significant here. There was no significant difference for nerve graft or transfer. For the gracilis graft, 88% of patients had private insurance, and that was significant. The average national ADI for these patients was 44. So that was actually the lowest ADI out of all the surgical treatments is for gracilis graft. And then for temporalis tendon transfer, majority were Medicare, but a good amount were private insurance as well. But again, the Medicare being the majority was significant. And then for neurectomy or neurolysis, 70% had private insurance, which was also significant. And there was no significance with the eyelid weight. This is just a summary again of that in a bar graph form. And we couldn't really use t-tests for this because some patients had multiple surgeries. So it was hard to make that comparison exactly, but we did find that the gracilis had, for whatever reason, patients were a lot less disadvantaged. And so then here for some conclusions, ADI is a new useful metric that I think is probably going to start being used a lot more in the medical literature for assessing disadvantage sort of spans beyond just race or insurance status. And then females are more likely to undergo non-surgical intervention. We found that with worse or higher House-Brackman scores, that corresponded with increased likelihood of surgery. Medicare patients are more likely to undergo surgery than Medicaid patients. And then again, the 5-point increase in the national ADI found that as disadvantage increases, they're more likely to have surgery. We're still sort of thinking about our conclusions that we can draw from that. And then this is limited to our patient population. State ADI, like I mentioned before, it's more difficult to compare here because we'd have to eliminate a lot of our non-Ohio patients, and it's not really fair to compare them on their own state level. And then some patients had multiple surgeries, like I mentioned, so we couldn't do that t-test at the end. And then the last point, I think, is something that we'll probably do next. We didn't really account for why these patients had facial paralysis in the breakdown of these ADIs. So I think it'd be interesting to probably look at those who had malignancy or iatrogenic causes of the facial paralysis versus Bell's palsy. So we didn't look at that yet, but it's a future direction that we can take. And then, like I said, we'll be tracking our EPIC order set utilization and follow-ups, and hopefully that'll be some future research that we can have and some way that we can actually impact patient care here and making a best practice advisory so that it pops up for everyone when you have a facial paralysis diagnosis. And then I just want to say thank you to Dr. Ciolek and then our wonderful medical students, James Zhu and Radhika Dugal, who helped with the statistical analysis of the ADIs, and then Derek Voss, who's helping with the order set. Thank you.
Excellent presentation, and I really like the topic and what you researched. Do we have any questions? I'll start off. So did you look at, because for the type of surgeries for surgical intervention they have, I would think like age may be one of the factors, like undergoing bacillus versus temporalis tendon transfer. Was that as significant?
I think we did look at that. I need to look back to see if it was definitely significant. It was significant in terms of surgery or not surgery though. And then we obviously Medicare, the people are going to be older, so that was significant too. But I'd have to look at the data sheet. I can't remember off the top of my head, but I think it was.
Great talk, Maggie. I was just kind of wondering, did you guys look at like the ADI of like people who had like non-surgical intervention? Were they like more disadvantaged, less disadvantaged?
Yeah, actually, yeah. So that was sort of what we found weird was that as the disadvantage increased, more people had surgery. So yeah, the people who did not have surgery, we didn't find that they were any less disadvantaged. It actually, I had a slide in there before, but it was just a little confusing about different insurances and the ADI, and it was just kind of all over the place, which I guess is good because it means that we're not, you know, we're sort of equally spreading the surgery.
Yeah, I mean, that's kind of counterintuitive in my
Right.
opinion. So
Yeah.
what do you think is like a potential rationale or reason?
The one thing that I thought of is that maybe people who are slightly more disadvantaged want just like a one and done surgery, and then they don't want to travel back and forth for Botox or travel back and forth and just want to sort of get it done. But that's sort of one thing that I thought of so far. I'm still thinking.
Maybe I missed it, but how did you calculate the ADI for each individual patient? Was it
Yeah.
solely based on like zip code or?
Oh yeah. So the question was, how do we calculate ADI? So it's actually based on their address. You need a 9-digit zip code at least to be as specific as it wants you to be, or the whole address. So we didn't like record it in our data sheet out of like patient confidentiality issues, but we just did each address as we went and calculated the score.
Just pumps out a number.
Yeah, the website is really cool. It just pumps out a number for you.
Do you think, so obviously you included patients who were like out of state. Are those patients maybe more likely to be kind of have like a lower ADI because maybe they have the resources to travel, and did that affect the analysis at all?
Yeah, that's a really good question. Ahmed asked, are the patients who are out of state, are they any more likely to have a lower level of disadvantage or a lower ADI because they're able to travel? And that's a great question. I don't think we found any statistically significant differences, but I'll have to double check. I didn't say anything about the states, but that would be interesting to report on too.
I know.
What? Thank you.
I was wondering, how would, like, what factors go into like, I'm imagining you could do, like, just look up the zip code of the patient and say, hey, what's the median income? in that
Right.
zip code?
Yeah. Malek asked what other factors go into ADI other than income. Some of the things are like your house. They look at the house, like how many bedrooms on average are in a house in this area. So a lot of things that are a little more nuanced in terms of, yeah. Catherine?
But did you look at, like, for our side, like, who was referring, so we can a lot of the referrals from community versus family medicine offices, and, you know, look at them different.
No, actually, I don't know about that, but that would be an interesting thing to look into. Catherine asked, did we look at the referrals where they were coming from, mostly the emergency room versus family medicine, internal medicine? That would be interesting too. But no, I didn't. We didn't. Look at that.
So is the plan for the order set to be just use an EP, or is the plan to get it out to all the primers?
Yeah, Cash asked about the order set. So the plan is to get it out to basically anyone who wants to use it. It'll be a discharge order set, but the best practice advisory will be more of one of those pop-ups that you usually click out of in Epic. And so hopefully people will click on them.
Good luck.
That we all read thoroughly.
But yeah, the goal is to have it for anyone to be able to use. Yeah.
Is it like associated with diagnosis?
Yeah. Mhm.
Emergency room uses those much more frequently.
Yeah.
For diagnosis, like they'll help you by something wants to get helps them with best practice guidelines. So, as it stands now, the referral goes to neurology, actually, but our discussions with the neurology folks really these patients. So there's trying to be a transition to for these patients. I mean, there is a chance that given the change in referral patterns, that you guys may just get like road-sided from the ED for consult. So it's helpful just to familiarize yourself with those guidelines. And it's always appropriate to refer them to our clinics, either Kristen's clinic or CD.
Yeah, I mean, the few patients that I've seen in my clinic that come for other reasons who have incidental history of Bell's palsy, like most of them are surprised that there are options, right? So I
Right.
think really education is key. Education, obviously, of our patients, but really the people that are, seeing these patients, primary care, neurology, ED.